I'm Jessica Lovell in the Dolph C. Simons Jr. broadcast studio in Olathe.
And good morning to our visitors from the Netherlands who are watching. I'm Alexis Del-Cid from our studio in KCK. The University of Kansas Health System is the official medical services provider for the Kansas City World Cup 2026 host city.
And as visitors from multiple countries gather in KC, we have been hearing many ways to say good morning. News agencies report up to 70 different languages will be spoken by players, spectators, reporters, all from visiting host cities. Visiting our host city.
That's right, and that's a small number in comparison to the 300+ languages and dialects that the interpretive services here at the health system handle regularly.
The greater Kansas City Metro is truly a melting pot of people, so we want to ensure that language is not a barrier to anyone coming through the health system doors.
Today we have Ashley Orozco Flores today, a staff interpreter, Ashley Flores Orozco, on the show, along with Jake Horner, success manager with Propio Language Services. Also joining us, we have Dr. Brian Beaver, the host city health and medical lead, Dr. Dennis Allen, medical director of venues, and Dr. Dana Hawkinson, infectious disease specialist and medical director of infection prevention and control.
Thank you. But first, we want to check in with our emergency medicine physicians. 2 weeks down of Fan Fest. Lots of practice, and the second match at Kansas City Stadium is tomorrow. Dr. Beaver, good morning. How are you?
Morning. We're doing great. Had a great first match.
Nice. I like to hear that. What kind of care have we been providing spectators inside KC Stadium?
You know, we're really fortunate. We're set up to be able to really take care of anything. You know, we do a lot of minor care, everything from Band-Aids to ibuprofen to Tylenol, all the way up to if someone's really sick, we've got the ability to get them stabilized there before getting them to an ambulance and transporting them on to a hospital. So we're able to do anything. Our goal, though, as much as possible, we want to be able to take care of them at the stadium and get them back to enjoying the event that they came to watch.
Absolutely. Dr. Allen, same question for you. We have first aid areas set up around the stadium. Describe the care that your teams have provided so far.
It's been pretty basic. It's been pretty what we expected. Really, the only thing that has happened out there that surprised me so far is that thousands of people can sing the same song in unison for an entire game.
Impressive, huh?
It's like a playlist. I don't know how they do it.
They all got the memo. It's nice.
I don't know. They change songs. It's amazing. But the medical care has been just exactly what we were ready for. They and the fans have just that have come to our first aid have just been terrific. They have been really, really fun.
Making it easy for you.
They really do.
Well, and it sounds like all these months and year or so of planning of having this big event here is being pulled off just the way you wanted it to. The National Weather Service says that we're going to hit about 86 degrees Fahrenheit today, 30 degrees Celsius. We know that the temperatures can be deceiving sometimes, even in the upper 70s and 80s. Dr. Allen, research published in the Journal of the American Medical Association reported that heat stroke related deaths have increased 117% since 1999, and that's mainly due to rising temperatures. It's going to get hotter and hotter. It's going to get more humid as we get closer to July. So how dangerous could it get for people gathering in this big area and maybe not keeping an eye on it?
Well, I think it's something, because as we talked about before, it's not just the heat, it's the humidity. When the humidity goes up, it just gets more dangerous because you just can't lose, your sweat doesn't help. You just don't lose heat. And I think that's when you have to be thinking about, if you don't feel right, maybe buying one beer at a time. And if you don't feel right, then you have to drink. You have to maybe get out of the sun, but you just have to be aware of it, especially as it gets more humid.
Dr. Beaver, could heat stroke happen to just about anyone? Who would be most at risk?
Absolutely. Anyone's at risk. Particularly we worry about are the elderly and the very young. They just don't regulate heat as well as anyone else does. And then also those that just aren't acclimatized to it, that aren't used to being in the heat, that suddenly go out and exert themselves. So those are the populations we really want to keep a close eye on.
Dr. Beaver, last night, my 79-year-old father told me, hey, I'm going to head down to FanFest. I said, what? I said, I didn't even know you were a soccer fan all these years. So, you know, when I hear you talking about the elderly, although he wouldn't like me calling him that, it does make you think about it. I was like, he's not used to being out in these kind of big crowds, but hey, more power to him.
Absolutely. Hydrate early and get cooled off when you need to.
Dr. Allen, heat stroke looks kind of like other illnesses. I mean, they can present that way. How do you determine when it is actually heat stroke?
I think that it's a little easier with exertional heat stroke. Because what we're looking for is we're looking for alteration in your ability to function, in your mental status. Now, sometimes out with our crowds, substances can make it a little confusing because there can be some alteration due to alcohol or other substances, but it becomes something we sort of learn to recognize. You know, after being out and doing hot events for the better part of 25 years, you sort of get an eye for in a fan that's different. They're altered, which is when we really worry about players. We're worried about altered anytime.
Sure.
We're taking that they're leaving the pitch.
The pollen count for grass is high, and a little bit better news, the mold is moderate. What kind of medical issues have you seen, if any, related to air quality, pollen allergies, things like that?
You know, we've had some basic things, but I don't think there's really been a big rush on that we've had to think about, and we haven't had to think about changing our medications out at the stadium. It's been all pretty basic so far.
So far, so good. Dr. Beaver, I want to talk about something else. Can you talk about the support that we have for patients who speak a different language, and how do we manage that when they arrive at the emergency departments?
Absolutely. So when they get to the emergency department, we have a number of things. We have combination of both in-person interpreters available, as well as our partners at Propio that we use the iPads regularly to be able to access more languages than I could possibly imagine. And I'm thankful for all the ones that we're able to find in there. And so and that it would include sign language as well. So American Sign Language is there. So whatever language that patient speaks, most of the time we can find someone who can speak so that we are communicating with them and we're caring for them in their language.
Dr. Allen, what about fans out at the stadium when they need medical care? How are we making sure that language barriers are not an issue?
We pretty much have the same equipment. We don't have the on-site live interpreters. We have the same equipment to access multiple languages, and I think it's what I've worked with for years in our emergency department. I really haven't run into there's just a language we can't handle over that language line that we use.
Yeah, not your first rodeo, so to speak.
Oh no, and we just do the same thing we do in the ER out at the stadium.
Well, thank you both for your information today. Dr. Beaver, I know you have a meeting and you have to jet, so we'll let you go. Dr. Allen, maybe stick around in case we have a couple of questions for you here in a bit.
Sure.
Alexis.
Jesse, I'm here with Dr. Dana Hawkinson, and in addition to Dr. Hawkinson's medical title, he's also a big-time soccer fan, and he played soccer from grade school all the way through college. So, Dr. Hawkinson, you're being modest about your soccer prowess. In fact, we uncovered an artifact. Take a look at this. Okay. We took a trip in the Wayback Machine.
Yeah. Wow.
Who is that handsome redhead?
Look at that. Freshman year of high school, yeah.
Wow, and you've got the haircut.
Oh,
the haircut to match it that
yeah.
everyone's mom gave him.
Yep.
So your son is also following in your footsteps, though. Tell us about your son and his game.
Yeah, so my son played all through, when he was really young, up through high school for for club and also played for his high school at Rockhurst. He's kind of gone on to college now and hopes to be getting, playing either intramurals or maybe even the club team soon. But otherwise, yeah.
All right. So this is basically your Super Bowl, having the World Cup, us being a host city. So, but let's dive into your professional expertise.
Yeah.
How are we doing from a public health and infectious disease perspective so far with all the crowds?
Yeah, I think we're doing good. I think the biggest indicator is going to be our emergency department visits, is when we've heard our two guests, or urgent care visits, but we haven't really heard of any big spike for anything in particular, especially for infection-related causes.
What's the wastewater monitoring showing us so far?
So in the United States, but also particularly here in our community in Kansas City, we do monitor wastewatering, not us, but KDHE in conjunction with another firm as well. Do wastewater testing, looking for certain viruses, especially respiratory viruses. As you can expect, those are all very low right now, but also check for things like norovirus, but also Mpox and things like that. But what we can say is overall, it looks like levels are very low or not detectable for these diseases. So that is good news. And that's good news because we know if we can start to see it in the wastewater, we can then eventually start to see it in patients and can expect a surge in some of those diseases.
A question for you. Earlier in May, Ebola and hantavirus made the news, but now there is something called, it has a gruesome name, the Texas flesh-eating screwworm.
Yeah.
What's that one? And is that here?
Yeah, I would say, we just call it New World screwworm, and what it is it's a fly which then lays its eggs in wounds or around wounds or things like the rectums of these animals. Those eggs then turn into larvae, which then burrow into the flesh, eat that flesh of the live animal. So really, we had removed that parasite from the United States since 1966. It's been in conjunction with Mexico and other Central American partners to help cause the extinction of that fly, or that safe barrier of our countries where you're not seeing that fly anymore. Well, those programs have been reduced over decades, and now we are seeing some cases of those in Texas and Arizona, and it can be a significant issue to livestock and, of course, then food supply and food chain, things like that. Not a lot of danger to humans right now, but certainly if you have an open wound and a fly does lay eggs in there, it could be. But mostly it's for the livestock and the farmers that we're thinking about. We don't have any cases or any concerns about it right now currently, but as we can see, these diseases, these animals, flies, ticks, what have you, they don't really adhere to borders and they will go wherever they want.
But right now, no flesh-eating screwworms here in Kansas City for people to worry about.
Correct.
Thank you, Dr. Hawkinson.
Yeah.
And if you're watching and you have a question you'd like us to ask our doctors, you can submit those questions to YouTube or Facebook by using the chat feature below, and we'll ask your questions live on the program. Also, if you're a member of the media, please tell us your organization and your name so we can identify you. Jessica?
Alexis, thank you. We are going to learn now more about how healthcare overcomes language barriers and what all is involved. Ashley Flores Orozco is one of the many interpreters at the health system, and she works here in Olathe. Good to have you.
Thank you for having me.
Good to have you. We're also joined virtually by Jake with Propio. How are you today?
I'm doing good. Thank you for having me.
You bet. Jake, explain what Propio is and how the health system uses your services.
Yeah, definitely. So Propio is a full suite language services company that provides both interpreting and document translation services across many industries with a primary focus on healthcare. We support the University of Kansas Health System with over-the-phone, video, remote, and in-person interpreting services.
You're joining us virtually today, but you're actually here in town to provide services as well. On any given day, about how many calls for help are you all responding to, and why the focus on providing human interpreters?
Yeah, definitely. We're very proud that Propio was founded right here in Kansas City in 1998, and headquarters remain here to this day. We typically provide virtual interpreting services for anywhere between 700 to 900 calls per day throughout the health system. And we also provide in-person interpreting support throughout the health system on a daily basis. And yeah, just to the second question, while Propio and the language services industry as a whole have come a long way in terms of technological advancements, we are of the belief that human interpreters will never be fully replaced in the healthcare space, because having that human-to-human connection is really essential when you're discussing a patient's health.
And it makes sense whether it's good news or bad news. You really want to hear it in person, have that personal touch. Ashley, how does medical interpretation differ from other interpretive services?
Yeah, it really just comes down to the safety of the patient. As a medical interpreter, you're not just interpreting words, word for word. You're actually, having to give these patients diagnoses or treatment options. So it's really important for the patient's safety to understand what's going on with them. So it's not just about the communication, it's all about the safety.
Well, and how, kind of on that note, how does having an interpreter really affect patient outcomes?
Yeah, so when patients are able to understand their health condition or their treatment options, they're able to play more of an active role with what they'd like to do with their health. So it's all about safety. Once they're able to understand any medical instructions, like discharge instructions after a surgery or something like that, then they're have better outcomes, and that makes it because they're actually understanding what's being done with them.
And what they need to do on their end, for sure. About how many interpreters do we have? How many are needed when it comes to a health system our size?
I know we have a handful of them. Here at the Olathe campus, we have about 3 full-time interpreters and 1 PRN. And then we have a larger group of ASL interpreters who also cover the whole health system. So we are definitely pretty busy and we love it. It keeps our day going pretty quickly. And we are also very grateful for the Propio help as well, because it's a lot of patients that come through here.
I bet. How quickly are you able to respond to a patient who needs your services?
Yeah, we're pretty quick, and we also rely on Propio a lot. If we aren't able to be with a certain patient, we have staff use the Propio tablet services, and we really prioritize patients who need someone, face-to-face communication. If we know that would make a difference with their interpretation services, we prioritize those patients.
So how did staff here at the health system kind of gear up to serve the additional people that are in town for the World Cup?
Yeah, so we already have a pretty big community of different languages that we already serve. But of course, we partnered with Propio to be able to serve as many more people that are coming through. So that has been a lot of help.
And Jake, same question for you. How did your teams prepare?
Yeah, definitely. We have an internal committee who's been meeting throughout the year to monitor the anticipated World Cup related language demand increases. And our operations team has placed extra emphasis on increasing our interpreter pools to support the expected increase in demand for these languages. On top of that, we also provided the health system with a fleet of additional iPads for the surge in demand for the World Cup that were deployed to key areas throughout the city, just to increase the number of access points that staff members have throughout the World Cup.
Well, Jake and Ashley, thank you so much, not just for being here, but for making sure that patients and visitors to our area are properly communicated with and feel welcome.
Thank you.
Thank you so much. Alexis, any questions today?
We do have some great questions, and the first one is for Ashley from Jill. Jill wants to know, what does it take to be a medical interpreter, and how long did Ashley have to study to be a medical interpreter?
Yeah, so it's actually a big misconception that if you're bilingual, you're automatically qualified to be an interpreter, but it's definitely not that way. To become a medical interpreter, it takes a lot of training, learning medical terminology, not only in English, which that can also be another language, but also in the native language as well. It takes a lot of training and code of ethics, different modes of interpretation. You can also go out and get nationally certified, which also takes some time. Medicine is always constantly changing, so really the learning never stops.
Medical language is hard to master in your first language, let alone in another language. It's really remarkable. Dr. Allen, we have a question for you from Scott. It's actually 2 questions from Scott. Scott wants to know, where are the first aid stations around KC Stadium located, and are there cooling stations?
Yeah, we have at least 3 different first aid stations. We have 2 up on the 3rd level. We have 2 down on the first level of the stadium. We also have a section. It's a room that they were very nice to give to us. That its only purpose is to just go cool down. And the security and the healthcare workers that are out in the stands can direct people either to our first aid, or just direct them to our cooling station, which is in section 107. Our main first aid that we can do most of our that we have most of our capabilities is right off section 114.
We have a question for Jake, and Jake, this one's from Allison. Allison wants to know if you're bilingual or if you speak other languages.
I'm not bilingual. I leave the interpretation up to the professionals such as Ashley, so not bilingual, but...
You speak business. You can get down to business.
Yeah.
We have a question for Cindy, from Cindy for Dr. Allen. Cindy wants to know if spectators can bring their meds into the stadium with them, and then she also wants to know, what do visitors do if they lose their meds?
Right. As far as what they will allow into the stadium, I think that's something to check before you come, because those rules are I'm not always aware of all of them. I do know what's going to happen if you come and you've lost your meds. One is if you have a medical condition that you need treatment for, and it's and you don't have your medication, we'll get you taken care of at the stadium. Now, as far as replacing those meds, we won't be able to prescribe new medications at the stadium, but we can direct you if you just need a new prescription to where that can happen for you.
Yeah, we did have a pharmacist on a couple of shows ago who said that if you don't live here, you've got to get a valid prescription from somewhere here, if you're from another country. Mm-hmm. We have one more question from Dawn. Dawn wants to know, with all the crowds, how will emergency vehicles reach people at FanFest or the stadium if they need to get somewhere that's through a big crowd? Is there a plan B if crowds are blocking the way? Dr. Allen, do you have any insight on that?
Oh yeah, man, we've been doing this for huge crowds for, like I said, for probably 25 years. And what we will do is we'll use carts, which get very effectively through the crowds. If we have somebody that needs to leave the stadium in an ambulance at times of traffic, and we've had to do this many times over the years, we'll actually park an ambulance out right outside the stadium at a gate, and we will take them in a cart. That is actually it's the size of a golf cart, but it's staffed and equipped almost like an ambulance, and we'll take somebody and drive them in that cart to the gate. And generally with the help of police and people are actually pretty darn good about moving out of the way. And with the help of police, we usually can get a patient to almost any crowd.
Those are some great questions this morning. Thank you to our viewers for submitting them. Jessica, back to you.
Well, remember that we have you covered on all things World Cup, bringing the very latest health updates in our live shows every Monday, Wednesday, and Friday at 8 a.m. Our next show focuses on celebrating safely between all the food and drinks, cheering all the teams, just having a really good time. What can you do to avoid anything that dulls the celebration, including unnecessary trips to the emergency department? That is coming up on Monday.
In the meantime, we've also produced some videos to help you with everything from emergency care to heat safety. You can find all of our videos on our website. The information on where you can find them is on your screen. Today's video can help you determine if you need to visit urgent care or the emergency department.
And then stay tuned for an encore presentation of the Morning Medical Update as we follow the story of a 39-year veteran firefighter who blew off his physicals and regular screenings upon retirement. We're going to tell you what finally sent him to the doctor and what they found right after this short video. Thank you so much for watching. Please stay safe this weekend, and we'll see you back here Monday at 8.
Urgent care or the emergency department. What is the right place for you to go when something is wrong? I'm Dr. Brian Beaver, an emergency medicine specialist. I want you to know when urgent cares are appropriate and when you should head to the emergency department. Head to an emergency department at a hospital if your life or limb is at risk. They treat more concerning medical conditions like chest and abdominal pain, difficulty breathing, signs of stroke, broken bones, and trauma. Urgent cares treat less serious medical conditions like fever, cough or sore throat, minor cuts, sprains and strains. If you are unsure whether your condition can or should be treated at an urgent care, err on the side of caution and go to an emergency department where a higher level of care is available. For our overseas friends, once you get to your lodging, take a few minutes to learn the area. What is your closest hospital and urgent care? You'll likely find hospitals nearby, but an urgent care may be even closer. There are more of them. Urgent cares are faster, easier to navigate, and more accessible. If you can't get somewhere, you call 911 for emergency help.
Coming up today, a retired firefighter faces prostate cancer, how he and his doctor work together to find the best treatment. Good morning, I'm Jessica Lovell and welcome to the Morning Medical Update. Today we are talking about a cancer that affects 1 in 8 men, but often goes unnoticed until it demands attention. Prostate cancer can be slow growing, easy to miss, and in many cases, though, highly treatable if caught early. Our guest today is a retired firefighter who spent decades putting his health and life on the line for others. Well, like many men, Jack Holcomb assumed his good habits and clean bill of health would carry him out throughout retirement. But an elevated PSA and some persistent symptoms changed everything.
I'm like, this is getting old. I don't like. I used to jump out of windows and climb ladders.
For nearly 4 decades, Jack Holcomb served as a firefighter.
I started in 1979. We didn't even have air packs for everybody. Then as the years went by, things started to come to light about health, not until probably the 90s or so, early 2000s, health and wellness. And it was a little too late then.
By then, Jack had already lost several firefighter friends, not on the job, but to various cancers brought on by environmental toxins doing the job.
We have a small group just from our department that have all been diagnosed with some type of cancer.
Guidelines changed and firefighters were required to have annual physicals, regular blood work, and their PSA check. When Jack retired and stopped working in 2014, he admits his screening stopped too.
It's like the military. When you're told to do something, you go do it. And then when I'm on my own, I didn't do so well.
No longer able to ignore the frequent urination, Jack just had a feeling. He finally saw a urologist, and the news was what he had suspected. He had prostate cancer.
I felt like the urologist I went and saw was really kind of pushing me towards doing the robotic surgery, the removal of prostate.
Jack wasn't so sure about that, so he referred himself to Dr. Ronald Chen at the University of Kansas Cancer Center, who had another option. SBRT, stereotactic body radiation therapy, a type of high-dose radiation treatment used for some early-stage cancers.
He said that an option of, instead of spreading the radiation out, we just do it in 1 week.
And just like that,
Sit.
Jack was back to what he calls quality of life, like making memories with his daughter.
She's like, I want you to spend my birthday with me. I'm like, sure. What are we going to do? Well, we're going to go skydiving. So we went skydiving. Yay! We went on another trip just a couple months later. So everything's been good, been great.
And reminds us all of this.
I look at it a lot different. I go to the doctor, I ask questions. We're not bulletproof.
And joining us this morning is Jack Holcomb here in our studio. Good to have you.
Thanks. Glad to be here.
Glad to have you. Also, we have Dr. Ronald Chen, the Chair of Radiation Oncology here at the Cancer Center and the leading expert in treating prostate cancer. Always good to have you, Dr. Chen.
Hey, Jess.
We also have in Studio B with us Kate Martineau, a nurse practitioner in the Department of Radiation Oncology, joining us from Studio B. Katie, how are you?
Good. Thanks for having me.
Good to have you. Together, we're all going to discuss really how far we have come in treating this disease. We're also going to talk about what every man should know about screenings and why quality of life is just as important as finding a cure. Jack, you mentioned brushing off that initial call about your elevated PSA. What was going through your mind at the time?
I was surprised. My PSA had always been normal, low, and I was a little shocked. Didn't know if I really needed to move forward with anything.
Yeah, because you've been really, diligent about getting it checked and staying up on it, right?
Right. Yeah.
Dr. Chen, for men like Jack, they have an elevated PSA, but they feel healthy. What's your message about why follow-up matters?
Yeah. So I think the principle here is we want to catch a cancer before it causes symptoms. We want to catch it as early as possible. And prostate cancer, fortunately, we have that PSA test that's able to sort of alarm us that something may be going on before a patient develops symptoms like blood and urine and whatever. And of course, as early as we catch it is when it's most curable. So my message is, if your PSA is elevated, get a biopsy, pursue it, don't delay it, because the early diagnosis means saving your life.
So could you tell, though, that Jack had put it off for a while when you met with him?
Actually, I think Jack has done a really good job. Jack's PSA was elevated, but not extremely so. Of course, as a person who specializes in prostate cancer, I've seen a lot of men who have really delayed it over the years. And I think part of it is fear. You have a blood test that's elevated, say something is wrong, you feel good, you're afraid of what a biopsy may show, so you wait for the next year, and then you wait for the next year, and then you wait for the next year. I've seen many situations like that, and I think that's really something that we should try to avoid.
Yeah, and that's tough because, when you're feeling good, right? You're always told, listen to your body. So let's turn now and let's talk about those signs and symptoms of prostate cancer, because in early stages, you may have no symptoms at all, and that's why the screening is so important. Some men experience problems urinating. They might have blood in their urine. Jack, what symptoms were you experiencing at the time?
Well, I went from not being an issue about urination to I was getting up 4 or 5 times a night. I was feeling sudden urges during the day, unexplained, that like immediate. And I just had an overall feeling of something wasn't right.
Something wasn't right. Yeah. Katie, I want to ask you, prostate symptoms, as we know, they can be awkward or embarrassing to talk about. How do you normalize the conversation with men, make sure that patients are feeling comfortable in sharing everything with you?
Yeah, of course. So prostate cancer oftentimes brings up very personal concerns such as urinary or sexual health issues. So the first thing I really try to do is to get to know the patient, try to create a personal rapport. Jack knows this. Sometimes you come in and we're just talking about family, travel, the Chiefs, of course, getting to know each other. And then I always try to make sure, we talk about how all of these symptoms are very common. They are normal. There's nothing to be embarrassed about. Every time you come to a follow-up appointment, I am going to ask all of the side effect questions. I think that really kind of lowers the barrier to entry if I ask the question, I find that people will often be a little bit more truthful and bring them up. And my goal is just to create a safe space where every question can be asked openly, and then that way we can give the best care and support.
And why is it so important to get to the truth? And how can that impact treatment?
Yeah. So I think that if we don't know what's going on, we just can't help you. I have had patients, so I see mostly follow-up patients. And I have had patients who have suffered with things that they didn't need to suffer from. I have had patients who have put off that once-in-a-lifetime trip because they were afraid they couldn't do it because of their symptoms, when really we had a really easy treatment that we could provide. So please let us know what's going on. So once we know, we can really start the care and the treatment that you need.
Jack, was it easy, hard talking about it? How did you kind of navigate those first initial conversations, and did it become easier over time?
Yeah, great question. The first ones were very uncomfortable.
Sure.
Dr. Chen made it feel very comfortable. I and my wife, and Katie's been great. So now it's just old hat when I see Katie, very open. But yeah, it was uncomfortable, something a man normally doesn't talk about with others.
Well, and thanks for sharing that, because that's why we have these conversations here openly, so that other men, when they eventually have to have these conversations with providers like Katie, that they feel comfortable doing that, right, Dr. Chen?
Yeah,
I mean, we want men to feel comfortable talking about it, because it can affect their treatment path.
Oh, absolutely. And I think just to be more specific, I think a lot of times we talk about what are your urinary symptoms, and we're very specific, going through a list of them. We talk about sexual function. I think sometimes people are a little comfortable talking about that, but I think Katie and I, when we see patients, we're very direct with, this is why we're asking you these questions. Please tell us how you're doing right now, so we can sort of track that over time. And I do think that practice makes perfect. Katie and I specialize in prostate cancer. We do this all the time, and I think our comfort asking these questions helps patients feel more comfortable talking about them with us.
Something very important, screening guidelines. Let's talk about those. It begins at 45 years old for average risk. The age for screening drops to 40 years old for Black men and men with a family history. It's 40 years old for men who have several family members with a history. PSA testing remains the main screening tool. And Dr. Chen, what about digital rectal exams?
I think a lot of people have heard that PSA is not a perfect test, and that is absolutely true. It is the best we have. It is a really good tool to screen for prostate cancer, even though it is not perfect. And what I think part of the imperfection is that even a normal PSA, sometimes people could have prostate cancer even with a normal PSA. This is where the digital rectal exam can come from. About 10% of prostate cancer is actually caught on digital rectal exam when you feel something abnormal in the prostate when the PSA is actually normal. And so I think an ideal screening would include both the blood test PSA and the digital rectal exam, because again, DRE can catch some cancer the PSA misses. But I would also say that some men are just uncomfortable having that exam. And if that's the case, still get a blood test, because that still catches the majority of prostate cancers.
Katie, anything else we should know about PSA tests?
I think exactly like Dr. Chen said, just please get your PSA test, know your number, and then we can go from there.
Should men with long-term environmental exposure, like firefighters, consider earlier or more frequent PSA testing?
That is not part of the guidelines. I think there could be some exposures that increase the risk, but there's not enough evidence to support increasing the frequency of screening for those men being beneficial. So we do not currently recommend that.
Jack, tell us the history, though. How did cancer awareness change over the course of your firefighting career? Because I know this is something you're certainly excited about, the changes for this current generation and generations to come.
Yes. In the beginning, it was never anything mentioned. Our gear remained dirty that we wore in all kinds of commercial, residential structures. We often took off air packs, our masks a little too soon, and inhaled toxins. But about the 90s, it became aware with the help of the International Firefighters Union pushing for health initiatives, and into the 2000s. And I worked for a very progressive department that was very supportive of that, and the city that funded that for the blood tests, the physicals. Now it's second nature, and it's saving a lot of lives.
And you've lost some friends. What has that been like for you over the years? Because you said I felt like I'm up next.
Yeah. So yeah, it's well known that it's a hazardous occupation. There's a lot of hazardous occupations, a lot of exposures in occupations and lifestyles out there, and this just kind of hit home, kind of like brothers. They were so strong, saw them being so physical, and then to have cancer hit. So that was an eye-opener. And then even now's retirement, fellow firefighters. We chat, ex-firefighters, and find out, oh yeah, you got diagnosed? Yeah, you went through treatment. So it's pretty common.
And you said you have a little group that visits?
Yeah, we initially, we contacted each other. It's like, well, what are you going through? What did you find? And what happened to you? And how did it go for you? So, yeah, we compared notes.
Certainly not something you thought you'd be talking about,
No.
20, 30 years ago.
Didn't look forward to that, no.
Sure. I want to talk about Jack's treatment. Dr. Chen, he had the option of robotic surgery that he had talked about before he met you, before he sought you out, or radiation. What are the main differences between those approaches, and how do you help patients make that decision?
Yeah, I think patients when the prostate cancer is caught early, like Jack's case, I think patients are in the fortunate situation of being able to actually choose surgery or radiation as treatments that can really have a high chance to cure the cancer. And I use the word cure purposely. When it's caught early, we can cure prostate cancer with a very high probability. And in early prostate cancer, surgery and radiation are considered equally effective. There's been a clinical trial comparing surgery, comparing radiation. They have followed these patients for 15 years or more, and the results are absolutely the same in terms of cure and recurrence and metastasis. So really, we think of these as two major curative options are equally good. So how do we help patients make a decision? I think Jack did a great job in seeking a second opinion. When you have two equally good options, you want to hear from a urologist talking about, this is what surgery is like, this is the effect, this is the recovery, the side effects. You want to hear from a radiation oncologist talk to you about, here are the different types of radiation, here are the effects, here's the recovery, here's the side effects, and then so then you can make an informed decision. So I usually encourage multidisciplinary consultation, talking to a surgeon or radiation oncologist, so the patients can make the best decision for them.
And Jack, what helped you choose radiation therapy over surgery? Because I think you had said you just did not want surgery. You'd made that decision, right?
Yeah, I wanted to do the least invasive, in my opinion. That had been my experience in the past with medical things. But just like Dr. Chen said right here, that's exactly what convinced us to go with him. He was very open, very honest about the comparisons. Even the cost was similar. I asked him of that, and he did a great job of explaining. And he could see, I believe, my reluctance. I had a trip to Jamaica planned coming up, and I was like, well, we got to put it off a little while. I want to go on this trip. He was very open to that. So just like he said here, is exactly why we decided to go.
Yeah, you said he was very matter of fact and willing to figure it out with you.
Yes.
Work with you.
Absolutely.
And Dr. Chen, explain how the timeline is possible, because normally radiation is spread out with daily treatments over several weeks. That's what we think of when we think of radiation treatment. But in Jack's case, he only needed a single week of treatment. How is that possible?
I think what ultimately makes this possible is that the technology, the accuracy of radiation has increased so much over the last 10 to 20 years. I often see patients who say, well, my father had radiation 25 years ago, and this is what it was like. Well, it's not like that today at all, just as technology has evolved. And with more accurate targeting of radiation, we can actually shrink low doses over 9 weeks of radiation to higher doses over a week, because we can target the prostate so accurately. And I would say that 10 years ago, prostate cancer was everyday radiation for 9 weeks. There may be still some groups in the country that kind of practice in that old way, but we have a lot of patients now here in Kansas City at our cancer center who choose the 1 week because it is more convenient. It is equally effective, if not more effective, than the longer course radiation, and it is highly precise and really with great long-term outcomes. And so I think technology improvement, having that to be able to offer to our patients, has really improved the patient's quality of life.
Jack, any side effects before or after, during or after treatment?
You know, nothing drastic, no. I mean, during treatment and stuff, I felt about the mid of the week when I'd rush home afterwards, and it was in June, hot, go outside, try to do a lot of yard work. I felt it was a little draining on me, but that could have been psychological. Afterwards, nothing immediate. Meeting with Katie, follow up and stuff. Just a reduced stream and urination stuff, but she was great talking through that and helping me out. No, I mean, I seem to bounce back pretty quick.
Pretty good. Katie, what are the most common side effects that you see with patients, and how do you help them manage those?
Yeah, so the most common side effects after prostate radiation would be like urinary changes such as frequency and urgency, bowel changes, and sometimes sexual side effects. The good news is that most of these are manageable and temporary. And so we have a lot of different treatment options for patients. Sometimes it's just some lifestyle and diet changes. Sometimes we send people to like pelvic floor physical therapy. We have a great group here at KU. And then we have medications. And so we really just kind of talk to the patient, figure out what their goal for treatment is. And then we just provide that ongoing support throughout every step of treatment and then beyond treatment.
Be sure to ask your questions. You can use the chat on YouTube or Facebook, or you can email the Medical News Network. All of that information is right there on your screen. What kind of follow-up do you have now, and has that affected your day-to-day life?
No, I mean, I meet with Katie about every 6 months. I'm probably a difficult patient. There's travels I have or other plans that pop up, so I have to change my appointments, but they've been great about that. They've been excellent, but that's basically it. I'm more aware of my health, and I guess Katie may say that I maybe have a long list of complaints or stuff, maybe has nothing to do with my treatment, but no, it's been great.
Katie, what's it been like working with Jack?
Oh, it's been a lot of fun. I think we've gotten to know each other really well, you know, and he's one of those patients where when I see him on the list, I'm excited to get to talk to him. You know, we're always gonna catch each other up on travel or family. And part of the fun part about this whole thing is that now that we're pretty far out, you know, sometimes we're not even talking about side effects anymore. We're just talking about the day-to-day, and that's when it becomes really exciting to see your patients as they progress through this.
I bet it is. Well, let's talk about family, like your daughter and this wacky thing she got you into, like jumping out of airplanes and skydiving. Yeah. Let's talk about the skydiving you did with her for her birthday. What did this moment mean to you?
Well, it was September 1st, that year follow-up after the radiation, and that summer, and I was feeling a little kind of maybe not as manly as I had been, you know, after this and this coming to light, and family members knowing about it, even though my wife and family were very supportive. And my daughter said, "Hey, I want to spend my birthday with you." I thought, well, that's great, you know, let's go, you know. And then she goes, well, I want to go skydiving. So yeah, we did.
That'll make you feel pretty manly, jumping out of a plane.
Yeah.
That's something that Dr. Chen and I will not be doing.
I was commenting before this show that I will never go skydiving.
Yeah, and Jack said, he goes, you should try it. I said, not happening. It is not happening.
No thanks.
So you've got us there, Jack, okay? Dr. Chen, what stands out with you, besides him jumping out of an airplane, what stands out to you about Jack in his case, medically or just personally?
Well, I think Jack, and thank you for doing this to raise awareness about prostate cancer. I think Jack's case is actually a pretty standard case that shows that with early diagnosis, if you have the courage to, you know, get your PSA check, get a biopsy, if it's caught early, you can have a curative treatment and kind of go on with your life. This is the success story, and actually it's very common if we catch it early. You can have treatment, it's a highly successful treatment, you can go on with your life and live it in a very good way. And so I think hopefully Jack's story will encourage other people to be able to stay on top of their screening and catch it early.
Before we get to questions from the community, I do want to go over some risk factors, though. There are many risk factors for prostate cancer. Chances increase as men age. So, of course, screenings generally, as we mentioned, begin at 45. Your race plays a role, too. Black men are 70% more likely to develop prostate cancer than white men. Your family history is an important factor, so know it. And we are learning more about the role of gene mutations like BRCA1, BRCA2. And if you were in the military, that increases your chance of prostate cancer due to possible exposures. Dr. Chen, though, is there much that men can do to lower their risk of developing prostate cancer? What are the lifestyle things that we can do?
Yeah, so actually, there's a lot of research. Of course, there's a lot of interest in doing things to prevent cancer. Unfortunately, in prostate cancer, there is no definitive research to show that doing this will absolutely decrease the risk. So currently, we do not have a definitive recommendation on what you can do to lower your risk. However, most reputable websites will encourage better diet, less red meat, more vegetables, more exercise, as things that may reduce the risk of cancer, and more research is needed.
Let's get to some questions from our community. Jeremy wants to know, you talked earlier about the frequent urination at night. Are there other symptoms as well to be on the lookout for?
Frequent urination at night could be a sign of prostate cancer, but honestly, it's probably more likely to be a sign of an enlarged prostate, which happens as men age. And so just because when you were maybe in your 20s, you never got up at night, and then when you became 60, you got up once or twice a night, that happens with age. That happens as prostate gets bigger with age. That is not necessarily a sign of prostate cancer. I think it could be, but most likely due to an enlarged prostate.
Lynn wants to know, could PSA be used to early detection for prostate cancer?
Yeah, PSA is the primary way to try to have early detection of prostate cancer. We recommend that men over age 45 or 50 to have a PSA checked once a year, mostly by your primary care doctor. That is a primary way how we can catch it early.
Jack, thank you so much for just being willing to share this personal part of your life and your story. That makes a big, big difference. What's the big takeaway from your story? What do you want people to know?
To heed what you hear from the doctors repeatedly, get checked early, follow up. And it's easier to handle it when it's at the early stages. And then prevention is better than trying to deal with a cure. But it wasn't painful, any of the process, and it wasn't difficult, and I owe it all to Dr. Chen and Katie. So thank you.
Thank you. Katie, what's the big takeaway today?
Yeah, I think if anything, just please get your PSA checked, know your number. Of course, we don't want to see anyone, in our office with a prostate cancer diagnosis. But if you do get that diagnosis, please come see us. And just let us help take care of you.
Thank you so much, Dr. Chen. Wrap us up on this Friday.
I think Jack's example of seeking a second opinion, I think, is so important. When you have a cancer diagnosis, the first doctor you see may have a recommendation which may be really good, but cancer is such an important diagnosis and such an important decision. Get a second opinion, see if there's other options that you may not have heard about before you make a decision, because that's a life-changing decision for the rest of your life. So second opinion when you have a cancer diagnosis, I think that's my takeaway.